Welcome to our symposium on shifting the wound healing paradigm, problem to practice. In this session, we will be discussing pre-existing management challenges for surgical, trauma, and chronic wounds. We'll also be outlining therapeutic interventions each of the speakers have explored and processes they have implemented to optimize healing in these wounds. We will also be exploring the use of polymeric membrane dressings as a non-pharmacologic pain management tool. I'm extremely honored to introduce our chairman, Dr. Anna Tribus. Dr. Tribus is an orthopedic surgeon from the Ukraine who graduated from Ternopil State Medical University. She has since worked as an esteemed medical doctor in both clinical research and clinical practice, with her specialty being in the field of orthopedic surgery and a generalized focus on advanced wound therapeutic management. Dr. Tribus moved to Norway and is currently a surgeon working at the Stord Hospital in Norway. She's also a member of the executive board of the Norwegian Wound Care Society. She will be presenting her clinical experiences with polymeric membrane therapy in her current practice environment later in this program. So please welcome Dr. Anna Tribus.
This symposium is financially sponsored by the manufacturers of PolyMem. The manufacturers have not been involved in, nor had any input into the clinical data collection and content of the presentations. The information you're about to view is unbiased and unsolicited. I am pleased to introduce you to our speakers. Our first speaker is Jane Hampton. Jane Hampton is a master qualified clinical nurse specialist with more than 25 years of clinical practice, with a current focus on improving the management of recalcitrant wounds in the community setting in both a clinical and cost-effective manner. Her historical experience has resulted in her elevation to a true expert level in the field of telemedicine, education, clinical practice development, and wound management and prevention. Jane's attention to detail and critical thinking expertise in the world of wound care will lead the attendee through her transformational interventions to optimize chronic wound care in her community. Our second speaker is Marianne Hess Lindell. She is a registered nurse with an extensive clinical background in the field of general and plastic surgery. She has been working as an OR nurse for the last 23 years and has spent the majority of that time specializing in plastic surgery in the acute care settings. Marianne's repeated clinical interactions with multiple types of surgical wounds led her to become active in the critical assessment and intervention planning for both pain control and wound healing outcomes. She will be presenting her clinical outcomes from the Hospital of Southwest Jutland in Denmark in the Department of Plastic Surgery, Plant Surgery. Please welcome Jane Hampton.
Thank you very much. As you heard, I am Jane Hampton and I am a specialist wound nurse working in the community setting. I am particularly interested in reducing the impact that hard to heal wounds can have on both patients and service providers. I work in Aarhus, which is the second largest city in Denmark, with a population of 350,000 spread over the city and the surrounding rural areas. Our community nursing services provide wound care to around 4,000 patients each year, or approximately 900 patients each week in patients' own homes, community clinics, and nursing homes. We have three main challenges with wound management for community nursing services. The first is slow healing or non-healing wounds. This is often related to the fact that the majority of our patients are over 75 years and often have comorbidities. So the first question we have is, can we find management methods that can improve healing rates? The second challenge is that not all the nurses have the necessary knowledge to appropriately use the range of wound products available to them, nor the skills to undertake sharp debridement, which can also lead to delayed healing. So our second question is, can we simplify wound management and still be effective? Our third challenge is the amount of resources used to manage wounds. Currently, 30% of our nurse-patient contacts each week are related to wound management, and we experience a 4% increase in the number of patients requiring wound care each year, with a subsequent increase in costs associated with wound management. So our final question is, can we reduce resources used in wound management? We had the opportunity to trial PolyMem on wounds considered to be hard to heal. We identified wounds that had been present for at least 4 weeks and were reducing an area by less than 5% per week. The wounds had to have been treated with evidence-based products, including compression where appropriate. We chose to limit the trial to just 3 PolyMem products, Standard, Max, and Wick, and the products were used for up to 12 weeks on each wound. Patients in the trial were treated by the usual nurses in patients' homes or community clinics. The trial included 29 wounds. These were predominantly pressure ulcers and venous leg ulcers. The average age of the patients was 74 years, with 12 patients aged over 80. The wound durations ranged from 4 weeks to 1.5 years, with an average duration of 5 months. 15 wounds had been present for longer than 3 months. We found that using PolyMem considerably increased healing rates. Prior to the project, the wounds had been reducing in size by on average 3.7% each week, although some wounds had not changed at all for some time. The green line on the graph shows the expected reduction in size over 12 weeks if we continued with our usual treatment and with a reduction rate of 3.7%. We can compare this with the actual healing rates under PolyMem, where the average wound size reduction increased to 11.5% per week, which is almost 3 times faster. After 4 weeks of using PolyMem, the wounds were on average 61% smaller, which is 4 times greater than the predicted 15% size reduction with our usual treatment. We can see from the graph that the size reduction rate was slightly greater in the first 4 weeks with PolyMem than in the subsequent weeks, and that wounds that healed reduced in size more quickly than wounds that did not heal. We have an example here of an 87-year-old lady with a traumatic wound on her lower arm. She has had the wound for 6 weeks and has been receiving daily dressing changes. After just 10 days with PolyMem Max, the wound is 28% smaller and only requiring twice weekly changes. At 4 weeks, the wound was 58% smaller, and we swapped to PolyMem Max. Final healing was slightly delayed because of hypergranulation, as we can see in the pictures. The wound healed at week 11, having had an average weekly size reduction of 29%. In this example, an 81-year-old lady has exposed tendon on her foot and necrotic tissue, which the community nurses were reluctant to bride in her own home. Amputation had been suggested, but she had said no because of the risks associated with her general poor health. We used PolyMem Max, which resulted in more granulation tissue and less necrotic tissue. At 12 weeks, it was on its way to heal. The weekly rate of wound area reduction increased from just 2% to an average of 10% whilst using PolyMem. PolyMem was also effective on those small persistent leg wounds that refused to completely heal, even though adequate compression is being used. In these 2 cases, with a duration of 6 months and 3 months respectively, when we started using PolyMem under compression, the wounds healed within a few weeks and have remained healed. None of the project wounds were expected to heal within 12 weeks, but during the trial, 13 of these slow and non-healing wounds went on to heal. That is 45% of the project wounds. Surprisingly, the 3 wounds that healed within the first 4 weeks had been present for between 12 and 25 weeks without previously showing signs of improvement. A further 5 wounds reduced in size by 75 to 80%. So overall, 62% of these hard-to-heal wounds actually healed or reduced considerably in surface area. So PolyMem addressed our first challenge of improving healing rates of hard-to-heal wounds. PolyMem also addressed our second challenge of simplifying wound management. We found that PolyMem removed slough and non-vital tissue without the need for mechanical or sharp debridement. Dressing changes often only required the replacement of a single product, or a combination of two products, for example, PolyMem Wick and PolyMem Max. Simplified wound management resulted in nurses using less time to complete each dressing change, which in turn addressed our third challenge of reducing resource use. The two major sources of cost in the community are nurses' time and the products used. A reduction in the frequency of dressing changes can address both these factors, and that is what using PolyMem resulted in for us. We received data on dressing frequency for 21 wounds. Prior to using PolyMem, these 21 wounds received 60 dressing changes a week, whilst in week 4 of the trial, there were only 42 dressing changes. This is a 30% reduction, and far above the 14% fewer wounds being treated. By week 4, the wounds were smaller and producing less exudate, which enabled fewer dressing changes per wound per week. The largest cost resource in wound management is nursing time. Time is influenced by how often a dressing is changed and how many minutes each dressing change requires. The previous slide showed fewer dressing changes per week, whilst the simplified dressing changes also resulted in fewer minutes being used. Prior to the trial, 21 wounds received 20.5 treatment hours a week. By week 4 in the trial, only 11 hours were used, a reduction by 46%. We can also compare treatment time over a longer time period. For example, for the 4-week period prior to the trial, nurses used 82 hours to treat these 21 wounds, whilst in the first 4 weeks of the trial, only 63 hours were used. This is a 23% reduction, or 19 fewer hours a week the nurses can use for other activities. We estimated the costs associated with both nurses' time and the wound care products used in order to estimate a financial effect of using PolyMem. By week 4, the average cost of per wound per week had fallen by 33%, largely because wounds were being treated less frequently. When we compare the combined weekly costs for treating the 21 wounds, by week 4, there is a cost saving of €620, which is 42% less than before the trial started. So to sum up, in relation to the 3 challenges we started with, when using PolyMem on hard-to-heal wounds, healing rates were 3 times faster than with usual treatment and resulted in 45% of wounds healing within 12 weeks. Wound management was more simple for the nurses, with fewer products being used and no need for debridement. A reduction in resource use was evident after just 4 weeks, with 30% fewer dressing changes, 46% less time use, and a 42% reduction in treatment-associated costs. Our trial demonstrates that using PolyMem products can reduce the impact of managing hard-to-heal wounds in the community for both patients and service providers. Thank you for listening.
Hello, my name is Marianne Haslindal, and I'm a registered nurse. I will give you a presentation about simplified dressing on skin grafts. I've been working as an OR nurse for the last 23 years, more than 10 years specializing in plastic surgery. I now work in Esbjerg in our unit for planned surgery, where we take care of admitting, operation and discharge of all day patients, operations for all types of breast cancer, all kinds of plastic surgery operations, except massive weight loss patients. As a specialist OR nurse, I'm responsible for teaching, improving and introducing new products, methods and instructions regarding all kinds of nursing care in the OR plastic surgery unit. We had several operations where the skin grafts didn't survive. We experienced patient discomfort when removing the multi-layer dressing after 5 to 7 days, as it got attached to the new skin, causing skin defects, pain, and time spent trying to soak up the dressing for an easier removal. We used a rather expensive multi-layer dressing on most of our skin grafts, using 2 to 3 different products on top of each other. And we had seen quite a few surgical site infections when we didn't use an antibiotic gas as the first layer on the skin grafts. So our goals was to achieve a more successful survival of skin grafts, including both split and full skin grafts. We wanted to achieve less painful procedures when the bandages were taken off, and we wanted to achieve less infections post-operative to the recipient areas. And also we wanted to use an all-in-one single layer dressing, saving time and money, having influence on the quality of life for the patients, and can we relieve pain, provide better outcome, and reduce time and resources all in one. So our interventions was in 2018, Dr. MD plastic surgeon Jesper Næsted mentioned our issues at the Nordic Plastic Surgeons Congress in Copenhagen, and a nurse from our plastic ambulatory, Marianne Anke, and I decided together with Jesper Næsted to look for an alternative dressing that could solve some of our problems. At the Congress, we were introduced to PolyMem products and decided to go ahead. In end of 2018, we did a trial with it, using PolyMem Vic, mostly with two different types of gauze underneath, mostly due to the concern that PolyMem Vic would get attached to the skin. The outcome was very good, 100% survival in 88% of the patients, and even without the layer of gauze, we had no difficulties removing the dressing. Our plastic surgeons unit decided to change their general instruction for the skin grafts dressing and prescribed using PolyMem Vic as a standard treatment guideline. During autumn 2019, we decided to do a larger survey, getting data from 75 patients and using only PolyMem Vic as a single layer dressing. We made a new protocol and started the survey in December 2019. And we also applied for a presentation at TAPS 2020. We wanted the assessment and data on survival of the skin grafts and the comorbidities with the patients. We took photos before, during surgery, and by the removal of the dressing in the ambulatory on the 5th to 7th day after surgery. We wanted to measure the patient's level of pain during treatment and removal of the dressing using the VAS score. We wanted to look at infection rates, and we also wanted to register the type of skin graft, if the skin was methed, if the method, and the method of applying PolyMem Vic with sutures or clamps using acetate gauze on top or not. COVID-19 changed all plans and even postponed EWMA and TAPS. Luckily, we can now present results from 40 patients. Our survey now includes 40 patients, average age 74 years. We include all types of patients, exclude only people with senile dementia who can't give their consent to participate. We ask for a written consent and they are told about the survey prior or during operation, which mainly are made under local anesthesia. Patients are given their own protocol and we tell them to bring it when they meet in the ambulatory, where we finish up the protocol. It gives the patients an unique opportunity to feel involved and gives them a kind of responsibility for their own treatment. The surgeon decides which kind of skin graft is used. It depends on the location of the wound, the size, the comorbidities, the age, and where the skin can be grafted from. The mesh is made by hand or machine. Often the larger skin grafts are meshed with a machine. They use sutures to keep the skin in place over the wound, and after that, they place PolyMem Vic in 1 or 2 layers. PolyMem Vic is precisely cut out to cover the wound and are attached with another round of sutures or using clamps. Some surgeons use an acetate gauze on top to prevent the sutures from tearing the PolyMem Vic. You will see the technique on some of the next pictures. We had a partial skin grafts in 15 out of 40 patients, full skin 25, hand meshed 13 and machine meshed 7, and 20 out of the 40 patients were non-meshed. In 28 cases, this PolyMem Vic was sutured and we used stable in 12. All the surgeons estimated it as fast and easy to use and apply. This example is a 70-year-old female with basal cell carcinoma on her ear. As you can see, the full skin is non-meshed and sutured around the edges. And if you look at the next picture, you can see the PolyMem Vic applied with small sutures around the edges. And the last picture shows day 8 with an easy removal of PolyMem Vic. No pain for the patient. The skin is fine, 100% attachment and survival. The nurse's job was estimated easy and no time consuming at all. Our next example is a 72-year-old male with basal cell carcinoma to the scalp in a large scale. His medication included clopidogrel. We did a partial skin machine mesh to him. And as you can see on the lower picture, the PolyMem was applied with acetate gauze on top of Vic, makes it easier to suture firmly without tearing the PolyMem Vic and keeping PolyMem Vic down onto the skin graft. And the picture from day 5, the PolyMem Vic had a hindrance a little, but was moistened, and then easy and smooth removal of PolyMem Vic with no pain for the patient. And the new skin looks nice and dry, 100% survival, and no signs of infection. This one is a female, 67 years of age, with basal cell carcinoma on her temple. As you can see here, the PolyMem Vic is applied again with sutures and an acetate gauze on top, which makes it easier to suture firmly without tearing PolyMem Vic. Shows her on day 6. Again, was moistened and then easy and smooth removal. The new skin, a little moist, but 100% survival. No signs of infection and no pain for the patient. The nurse is happy. This one, a male, 79 years of age, comorbidity is distal carcinoma behind his ear. As you can see on picture 2, skin graft with machine meshed and sutures around the edges. And again, PolyMem Vic is attached with the acetate gauze. And then the last picture is where PolyMem Vic is removed on day 7. It's soaked with a bit of water for an easy removal. The skin is nice and dry, 100% attachment, no signs of infection, and the nurse noted 8 on the scale for satisfactory removal of the bandage. The patient had no pain at all. This last one is a male, 97 years of age. Skin on his ear, non-meshed and fixed around the edges, and a suture in the middle to keep it in place. And then PolyMem Vic is fastened with clamps to keep it down onto the skin. And the last picture coming in is the removal, which showed for the nurses an easy removal, a nice and dry graft, no pain, no signs of infection. The nurse noted 10 on her satisfaction scale. As you can see on our numbers here, we had some patients with comorbidities and medicine, and the numbers also show an average attachment of 84%, and that's even despite diabetes or taking blood thinners medicine. The nurses who removes all kinds of dressings and treat wounds in our outpatient clinics has been asked to evaluate each patient in the protocol and give their opinion on PolyMem Vic. Is it easy to remove? Time consuming? Does the patient experience pain using the VAS score? Are the nurse satisfied, happy working with PolyMem Vic? Only 3 times out of 40, the PolyMem Vic is hard to remove, takes time, and in just one of these cases, removal is causing pain to the patient. Total average VAS score was 1.8, and the nurses estimate PolyMem Vic as an easy and satisfactory dressing to use, 8.3 on a scale from 0 to 10. Economy before and now. The trial in 2018 showed use of a nitrofugas antibiotic gas in 7 out of 15. because the surgeons wanted to prevent infections to the skin graft. Now we use only PolyMem Vic and have an average saving of 62% on the skin graft dressings. We had 3 patients with signs of infection. We have a male 60 years old on his ear who was treated with antibiotics 1 day before removal, and even the attachment was 80%. And another one, a male 77 years old who had redness and signs of inflammation. The attachment was 85 to 90%, even though that on day 7. He was diagnosed with clinical infection on day 7 and got some antibiotics and a silver dressing on top, and healed after 1 month without further surgery. The last one was a male 78 years old, had started with antibiotics only 1 day after surgery. The attachment was only 10 to 20% on day 7. He didn't have any comorbidities, and the wound healed after 2 months without further surgery. We consider, could we have used PolyMem Vic Silver, and would it have made a difference to these skin grafts from the beginning? To sum up, in relation to all the 3 challenges we started with, when using PolyMem Vic, we can improve attachment and survival rates, we can reduce the incidence of surgical site infections, we have a fast and easy to use single layer dressing that is tissue friendly, low level of pain for the patients, and time saving. We get an average cost saving of 62% per dressing. The ongoing survey of data demonstrates that using PolyMem can address challenges and simplify dressings. And our new treatment guideline increases quality of life for the patients and saves time and costs for the hospital. Thank you very much for listening.
Dear Jane and Marianne, thank you very much for a fine presentation and the clinical outcome that you dealt with us. And now I want to present to you a surgeon's clinical experience using PolyMem for finger injuries. I work in Sturt Hospital, surgical department with closed work in Tissue Viability Center in our hospital. Our team consists of the head of surgical department, specialist in orthopedics and general surgery, Dr. Günther, and nurses who works in the same department. We work with all types of wounds from acute injuries to the chronic wounds. Here you can see Dr. Tribes in deep concentration who doesn't have time to make pictures. In 2017, we started a clinical evaluation of PolyMem finger on all acute fingers injuries and postoperative finger wounds. In total, we have followed up approximately 100 patients. The results of the clinical evaluation will be presented in the following slides. Okay, our problem is damage associated with finger injuries. In our project, we decided to include the patients with mild injuries such as mineral serrations, animal bites, foreign bodies and paronychia, severe injuries such as deep wounds with major damage to nails, bones, fracture and amputation, tendons, ligaments and nerves. What we get in the result? Our project shows that damage of tissue is job of surgeon. Pain, tenderness, edema, risk of infection is job of PolyMem. And what we get? No or less significant pain during dressing change, local exudate management, infection management and prevention. Our clinical management. We explore a wound to assess damage. We clean wound to remove dirt, debris. Suture soft tissue, tendons if needed. We use absorbable stitches, Vicryl, Novacin to adapt the skin on fingers. Perform plastic surgery to nail beds or if needed. Apply skin grafts if needed. Apply PolyMem finger dressing. Our follow-up procedures. Initial dressing changes 2-3 days after trauma and or surgery. Next dressing change 7, 14, 21 to 30 days, 5-6 weeks after surgery. In some cases, we need to make new revisions, amputations. In most cases, there is no need for dressing other than PolyMem. Dressing changed when more than 75% of dressing is saturated with exudate. PolyMem dressing can stay in for up to 7 days if there is no much exudate. Often, patients can change dressing themselves. The next slides will present our clinical cases and our clinical evaluation. The first clinical case is the boy, 20 years old. He damaged his finger, cut it off with the scissors. As a result, a big damage of soft tissue with nail and bow amputation. It is impossible to treat this wound with skin graft because we cannot put the skin on the damaged bone. We decided conservative treatment with PolyMem finger dressing and antibiotics because of the open fracture. Here we can see the result in 1 week. We can see the brown scab or the bone. It is dry necrosis. 2 weeks, the same scab, important that it should be dry. 4 weeks, just continue your treatment with PolyMem dressing, changes 1 time per week by the boy himself. 8 weeks, the same scab, but it is not fast in the wound, and I decided to remove it. As a result, intact skin and part of nail, but with the deformation of distal phalange as expected. But we decided to continue with PolyMem dressing and cortisone liniment and follow up. Here is 10 weeks and here is 10 months. Good result, we are satisfied. The clinical case number 2, 68 years old woman who crushed the finger under the approximately 40 kilograms weight and got the injury with partial amputation. Here we had to do the surgical intervention, wound revision, removal of bone fragments, reattachment of nail, and applied PolyMem. Here we can see the results after 3 days. No inflammation, no necrotic scab. In 1 week, we can see just some scab. 5 weeks. Please pay attention that it came some scab with dry necrosis. 10 weeks, 8 weeks, and 10 months. The most important thing that we observed during our project, after several days, weeks, the finger could be black and you can be confused, necrosis, gangrene, but as you see, you don't need to remove the scab. Make any revision as long as it is dry and not without inflammatory reaction around the wound. Clinical case number 3. The boy, 8 years old, crushed injury of fingers that caused to partial amputation of the distal phalange. Here it was also surgical intervention with wound revision, removal of bone fragments, reattachment of nail in the nail matrix, PolyMem dressing and antibiotics during 1 week because of the open fracture. 2 days, black scab, necrosis, maybe. 2 weeks, more necrosis. 5 weeks, dry black necrosis. 2 months after removal of scab. It is recovered. Next clinical case presents 22 years old man who crushed the finger in bicycle wheel that caused to the partial amputation and loss of soft and hard tissue. Surgical intervention with skin transpositional flap and PolyMem dressing. After 1 week, it was black scab. 3 weeks, the same. 6 weeks, recovered. Next one, 32 years old woman, partial amputation with the axe. Tried with the transpositional skin flap. After 3 days, we can see skin necrosis. 2 weeks follow-up, fluid under the scalp, much pain, so we should to remove the scalp. Here you can see 8 weeks and 14 weeks, it is recovered. Here you can see the clinical case with the dog bite of the finger. As a rule, all these patients with such a type of wound require antibiotics and tetanus vaccination. After 3 days, everything is great. After 1 week, we can see fat necrosis, debridement is made. 2 weeks, no exudate. 6 weeks, recovered, perfect. Next slide, we can see the 58 years old man, crushed finger with a stone caused to the partial amputation of the distal phalange. Here again, we don't have enough tissue to cover the bone. Actually, it was our first patient where we decided to follow up treatment with PolyMem dressing alone right on the bone. As a result, we observed that over the bone with PolyMem usage, it comes granulation. So here 2 days, wound is clean. 10 days, some granulation over the bone. 3 weeks, more granulation. 4 weeks, here we can see dry scalp. And he should come to new follow-up appointment 8 weeks after injury. But he canceled the appointment because the wound was totally closed. And the last one, clinical case. Here is 69 years old man with crush injury that caused to partial amputation. No big surgery is done, just adapt the skin with absorbable stitches and PolyMem apply. Here you can see that the dressing was not changed during 5 days. It's not desirable, but you can see that the wound is clean. And here is the results after 2 weeks and 4 weeks. After 2 months, it is dry, very, very little scalp, and it's recovered. Our section conclusion. The introduction of PolyMem finger has been a success at our clinic. It has become the treatment of choice for all finger injuries in our clinic. We see consistent results in wound healing and a significant reduction in pain level between consultation and dressing changes. Most patients can change dressing themselves. Our program conclusion. Surgical, traumatic, and chronic wounds all present unique healing and pain management challenges. The goal is to optimize therapeutic options through evidence-based evaluations of products. PolyMem has been scientifically and clinically proven to heal wounds faster while minimizing or eliminating pain. Thank you. You can now submit questions through the chat application.